Good day. We are on a tight schedule and our first speaker is here, so we're going to get started. It is my absolute pleasure to welcome everybody to our 8th Best of SWOG. Today's presentations certainly highlight our best work and our best investigators from new to less new. Each presentation is going to be about 8 minutes with 4 minutes for questions, and we will stay on time. So with that in mind, let me introduce Dr. Kendra Sweet, who will be updating us on S1612.
Great, thanks so much. And I apologize in advance. I'm working from home and the neighbors just came, their lawn people just came, so I'm sorry if you hear my dogs. They don't appreciate the lawn people, but hopefully they'll be quiet. But at any rate, I'm Kendra Sweet from Moffitt Cancer Center, and I am going to review some of the data from our randomized phase 2 trial of ruxolitinib plus TKIs versus TKIs alone in chronic phase CML patients with molecular evidence of disease. This is also called S1712. Next slide, please. So just as a brief background, treatment-free remission, or TFR, has become a mainstay therapeutic goal for many of our patients with chronic phase CML. So the first TFR study that was done was the STIM trial, and this one was really proof of principle that TFR is feasible in a subset of patients. At 77 months, 38% of patients on the STIM trial remain in TFR. The last study is another TKI discontinuation trial that's been done in the United States, and they reported nearly 61% of patients remaining in TFR with a minimum of 3 years of follow-up. I think what was even more exciting coming out of the last study is that they were able to objectively show what I think many of us subjectively believed, which is that treatment-free remission is associated with an improvement in health-related quality of life, and you can see some of that data shown here. So based on this data and a number of other discontinuation trials that have been done, both the NCCN and the ELN have incorporated TKI cessation into their guidelines. So the NCCN requires, there's a whole page actually of the NCCN guidelines for criteria that patients need to meet, but some of the main criteria that they require for patients to be eligible to come off treatment is a minimum of 3 years on TKI, a molecular response of MR 4.0 or deeper that's maintained for a minimum of 2 years, and then no history of resistance to therapy. But even with all of this, if we look at all of our newly diagnosed chronic phase CML patients, it's maybe 50% who will actually meet the criteria to be eligible to attempt stopping, and then approximately 50% who are going to have a recurrence. So we're still talking about 70 to 80% of our newly diagnosed patients who require long-term TKI therapy. So ideally, we need to continue improving our treatment so that we can improve these numbers. Next slide, please. So one big question is, why is it that we're unable to get more patients to a deep enough molecular response to make them eligible to discontinue treatment? So one theory is that the bone marrow microenvironment provides a protective niche whereby the leukemic stem cells are able to evade the effects of BCR-ABL TKIs. One hypothesis is that the phosphorylation of STAT3Y705 is responsible for establishing this microenvironment. So then the next question is, if we could inhibit phosphorylation of STAT3Y705, could this eliminate this protective niche in the bone marrow, expose the stem cells, the leukemic stem cells, to TKIs, deepen molecular responses, and allow more patients to come off treatment? Next slide, please. So that hypothesis is ultimately what led to the development of S1712. So eligible patients for, I should back up and say ruxolitinib, I think many of you are well aware of this, but ruxolitinib is a JAK2 inhibitor that also inhibits TYK2, and JAK2 is upstream of STAT3Y705. Thus, if we can inhibit JAK2, perhaps we can inhibit the phosphorylation of STAT3. So eligible patients are those with a confirmed diagnosis of chronic phase CML who are 18 years of age or older, receiving any first or second generation TKI. They cannot have any history of resistance to therapy, and they needed to have achieved at least a complete cytogenetic response, but still have detectable BCR-ABL transcripts measured by PCR at the time of enrollment. And the minimum time on treatment prior to enrollment was 12 months. Patients were then randomized 1-to-1 to single-agent TKI versus TKI plus ruxolitinib. They were stratified based on TKI as well as years on treatment prior to enrollment. Study treatment continued for a total of 12 months, at which point those patients on the combination treatment discontinued ruxolitinib and continued their TKI. The primary endpoint of this study was rate of MR 4.5 at 12 months. This was a phase 2 study, so it was designed with a one-sided alpha of 0.1. Next slide, please. The baseline characteristics of all patients are shown here. You can see we enrolled 38 patients in the single agent arm and 37 in the combination arm, and there were no significant differences between these two groups. I do want to draw your attention to the time on TKI, where approximately 60% of patients in each arm of the study had been on treatment anywhere from 1 to 4 years at the time of enrollment, which leaves 40% of patients on both arms of the study who'd been on treatment for 4 years or longer at the time that they enrolled. Next slide, please. So this study met its primary endpoint of significantly increased rate of MR 4.5 at 12 months. As you can see here, 14% of patients in the combination arm achieved this response versus 3% in the single agent TKI arm. Next slide, please. We know that the slope of the decline of BCR-ABL transcripts also holds some prognostic relevance with regard to treatment-free remission. So we wanted to look at that in the study as well. And you can see here there was a statistically significant difference in that slope of decline, where it was significantly steeper in the combination arm compared to the single-agent TKI arm. Interestingly, it was very much the same at months 3 and 6, and then after month 6 is when that slope really started to decline. Next slide, please. So all of this data was exciting, and we were pleased to see a positive study, but at the end of the day, I think most of us would agree that deepening molecular responses strictly for the purpose of deepening responses doesn't really improve the patient's long-term outcomes. So we needed to establish some clinical relevance to this data. And what we really wanted to know was, is this combination going to allow more patients to meet the criteria to eventually come off treatment? So at the time of data cutoff, we had 51 patients who had at least 2 years of follow-up after discontinuing study treatment. And these are the patients we analyzed to determine how many now meet the NCCN criteria to discontinue. And again, we saw a significant increase in the number of patients eligible to stop, 29% in the combination arm compared to just 11% in the single agent arm. So to me, this was the most exciting data that came out of this study, is that we are seeing more patients who now are able to attempt stopping treatment. Next slide, please. With regard to safety, this slide shows the non-hematologic adverse events. The vast majority of all adverse events were grade 1 or grade 2. There was an increase in adverse events, grade 1 and grade 2, in the combination. But again, very few grade 3 or higher adverse events. There are 5 in total, 3 of which occurred within the same patient. One patient did develop respiratory failure secondary to a PJP infection. But overall, the combination was well tolerated. Next slide, please. This slide shows the hematologic toxicity, and as you would expect, there was a higher incidence of grade 1 or grade 2 anemia in the combination arm, but overall, again, it was relatively well tolerated. Next slide, please. So just to conclude, the addition of ruxolitinib to TKIs in our chronic phase CML patients is associated with significantly increased rates of MR 4.0 and MR 4.5 at 12 months. Significantly more patients who were treated with ruxolitinib are now eligible to attempt TKI cessation. The combination was overall well tolerated, and at this point we have additional work ongoing trying to characterize which patients are most likely to benefit from the addition of ruxolitinib. At the end of the day, we still need to study this combination further in a large phase 3 trial to determine if it truly can lead to higher treatment-free remission rates. And that's all I have for you. I'm happy to take any questions. Thanks so much for your attention.
Great. So I'll encourage everybody to put questions into the chat for Dr. Sweet. I'll ask the obvious one. Agree that the combination should be investigated. What would that study look like if you were designing it?
Yeah, that's an excellent question. And it's going to be a hard study to do because I think, again, right now we have maybe 50% of patients who are able to come off treatment, and then 50% of those who end up relapsing. So it's going to need to be a pretty large study. But I think it would be something where patients who have molecular response somewhere between CCYR and MR4 after a year on treatment can get ruxolitinib versus not, stay on it for a year, come off, and then those who are eligible can discontinue. and then we have to follow for TFR rate. So it'd be a very long study, and it needs to be quite large so that we have enough patients in that TKI cessation part of the study to actually get relevant data.
Do you think there'd be enthusiasm in the heme community for conducting that type of trial?
I do. I think that, you know, when I've presented this data at the CML meeting in Prague last year and then at EHA as well, there was actually a lot of interest in this study and interest and excitement in the combination. There have been a number of combination studies that have been done in CML. This is the first one that's actually been positive. So so I think that there is enthusiasm. But CML studies are hard to do because a lot of people, those patients will oftentimes stay in the community at sites that aren't opening trials. But I think if we can really get it out there and really get it advertised and get enough sites up and running, then I do think that there's enthusiasm from the hematology community.
And my final challenging question, given that difficulty, do you think anybody's going to try and identify patients who would likely benefit and just do this?
Yeah, I mean, I think probably, especially knowing that ruxolitinib, and this is another concern I have moving forward, but ruxolitinib is going to go off patent sometime in the next couple of years, and so it won't be as hard to get. Insurance will, you know, cover it because it won't be expensive. So, yeah, I think there are a number of potential challenges with doing a larger study, but I really would love to be able to get it done.
So would I. All right. Thank you, Dr. Sweet, for that presentation. Now I'll introduce Dr. Kanwal Raghav, who's going to be talking about S1613, a trial in HER2-positive metastatic colorectal cancer.
Hello, Dr. Blanke. Can you hear me?
Yep, you're perfect.
Great. Hello, everyone. I'm Kanwal Raghav, one of the associate professors in GI Medical Oncology at the University of Texas MD Anderson Cancer Center. And I'm really excited to share with you the results of SWOG-1613. This is a randomized phase 2 trial of dual anti-HER2 therapy with trastuzumab plus pertuzumab compared to the then standard of care cetuximab irinotecan in patients with RAS, BRAF wild type and HER2 positive metastatic colorectal cancer. Next slide, please. So the background for this study is that HER2 amplification, just like in breast and gastric and other tumor types now, represents a small but a fairly distinct subset of colorectal cancer. This is seen in about 2 to 4% of all colorectal cancers, but most of these tumors are enriched in RAS, BRAF wild type patients. And the reason why this is very critical is that you can imagine that EGFR, which is a very active mechanism in colorectal cancer, is HER1 and HER2, and these share common pathways. So in traditional literature, it has been shown that when you have a HER2 amplified colorectal cancer within a RAS BRAF wild type tumor, you don't respond very well to anti-EGFR therapies, which is actually the standard of care for these patients who are RAS BRAF wild type. So some of this light that we shed on this study tried to answer that question. Furthermore, we also found that in preclinical data, you can see that they don't respond to anti-EGFR therapy, but they do respond to dual anti-HER2 therapy. They don't actually respond to single agent anti-HER2 therapy, which is very distinct from what happens in breast cancer and gastric cancer. Next slide, please. So the clinical rationale for this study came from some of the experiments that showed in patients that when you have a HER2 amplified tumor and you're treated with an anti-EGFR based therapy, your progression-free survival is less than 3 months compared to those that have a HER2 non-amplified tumor where the progression-free survival is 8 to 9 months in a second line setting. At that time, of course, this was not widely recognized as an established resistance biomarker for anti-EGFR therapy. And during this time, there were single-arm studies in treatment refractory colorectal cancer, starting with Heracles in Italy, which tested trastuzumab and lapatinib in HER2-amplified colorectal cancer. And then the US study, which was the MyPathway study that looked at trastuzumab and pertuzumab in a treatment refractory RAS, BRAF wild-type HER2-positive population and showed a response rate of nearly about 30 to 40%. Even in this study, you could see that when you look at different levels of gene amplification, you can see more responses. So when you look at the gene amplification in 0 to 50th percentile, response rate was about 25%. When you look at 50 to 100 percentile, it was 65%. So there was already an indication that HER2 amplified patients don't respond to anti-EGFR, they respond to dual anti-HER2, and this may somewhat be dependent on the HER2 levels. Next slide, please. So this is why we designed SWOG 1613. This was a randomized trial for HER2 positive patients with a central testing who had progressed on 1 or 2 prior lines of treatment. These patients should not have received prior anti-EGFR, although prior irinotecan was allowed. Patients were screened centrally during that step 1, during any line of treatment since the diagnosis of metastatic cancer, because it was a really low prevalence biomarker and we didn't want to miss any of that, and it wasn't the standard of care testing in colorectal cancer at the time, and was randomized to trastuzumab, pertuzumab, and cetuximab irinotecan with a primary endpoint of progression-free survival. The study actually didn't complete its accrual, which highlights some of the challenges that are associated with biomarker-driven therapies, in addition to the fact that during the time, there were other anti-HER2 therapies that were being investigated in the population. Patients were treated with TP and Satiri according to standard of care protocols. Next slide, please. So these are some of the results. This is the primary endpoint of progression-free survival. And you can see that in an eligible unselected population, there was no significant difference that was observed within the PF progression-free survival or overall survival, although there is a tail to the curve that you can see on patients that were treated with TP. This was despite the fact that out of the 26 patients that were randomized to Satiri, 20 patients had already crossed over to trastuzumab, pertuzumab. So I want you to keep that in mind as we go through some of this data. When you look at the response rate, again, very similarly, in an unselected population, it appears that the response rates are present in both cetuximab, irinotecan, as well as trastuzumab, pertuzumab population, which was contrary to the beliefs at that time that these patients may not respond to anti-EGFR therapy. Next slide, please. So this is the money slide for this study, right? So this is something that's very exciting that we were able to do this with a randomized trial, which we haven't been able to do in any of the other HER2 trials, which have been non-randomized and non-comparative in nature. So when we looked at the level of HER2 amplification defined by HER2 CEP ratio and gene copy numbers, high amplification being defined as HCR greater than 5 or gene copy numbers greater than or equal to 20, you start to see something very interesting. So when you look at these numbers, what you find is patients on TP that do the best are those that have high level of amplification. So look at the gene copy numbers of greater than 20, and their median PFS is 9.9 months compared to 3 months when the GCN is less than 20, and the numbers flip when it comes to cetuximab irinotecan. The same thing happens with the response rates, where the maximum response rates are seen with TP greater than 5, where the response rate is as high as 47%, and almost no patient with a HCR less than 5 responding to TP or a gene copy number of less than 20, very few responses. And cetuximab irinotecan seems to be the opposite. So we found a significant interaction effect between the treatment and the level of HER2 amplification. I think this is by far the most important lesson from this study. Next slide, please. So from a safety perspective, we also found that TP was a very well tolerated chemotherapy, cytotoxic chemotherapy free option, with grade 3 adverse events occurring in literally half the number of patients compared to irinotecan and cetuximab. Diarrhea is a common side effect between these two. And even though the number of patients having diarrhea were similar, almost all patients on TP arm only had grade 1 and 2 diarrhea, with grade 3 and 4 events in Satiri as high as 8%. Next slide, please. So in conclusion, we feel that SWOG 1613 established dual anti-HER2 as a well-tolerated, efficacious, and parenteral non-cytotoxic chemotherapy treatment option in RAS-BRAF wild-type HER2-positive metastatic colorectal cancer. And even though the low accrual limits limit our conclusions with regards to the primary endpoint, it did give us some valuable insight into the interaction that we see with anti-HER2, anti-EGFR, and HER2-positive metastatic colorectal cancer. And it seems like HER2 amplification, unlike most other biomarkers, tends to act on a spectrum, with low-level HER2 amplified tumors not addicted to HER2 and have ability to respond to anti-EGFR therapy, whereas the high levels that are very addicted to HER2 will respond better to anti-HER2 therapy and unlikely to respond to anti-EGFR therapy. I think SWOG 1613 was a pivotal study, as in being the first randomized trial comparing efficacy of dual anti-HER2 therapy against standard of care. It did establish the precedence and the role for central screening for a very low prevalence biomarker for which that testing was not allowed anywhere else as standard of care. And SWOG 1613 enrolled across 36 NCTN sites, but nearly a third of all its patients were accrued from the community oncology research program sites, stressing the role of community participation in these biomarker-enriched trials. And clearly, it has propelled HER2 into the next era of precision therapy in colorectal cancer, as is evident from the recent approvals of tucatinib, as well as trastuzumab deruxtecan in metastatic colorectal cancer. I'll stop there and happy to take any questions.
Great. Again, please put your questions in the chat. In the meantime, do you have any thoughts on effective strategies for testing rare subsets of rare subsets with potential targets? If you wanted to look at only a high gene expression HER2, which is already rare enough, what would you do?
So I think that this, this has sort of become less of a challenge now than it was back in 2016 when we started. As novel therapies arise, Dr. Blanke, I firmly believe that they are being incorporated into standard of care testing by themselves. So for example, HER2 testing for IHC as well as amplification is now a standard part of almost every platform that you're using. So multi-sequence, multi-biomarker testing is the way to go as being most efficient. The trick is to be able to do these biomarker testing early in the sequence. And I think that's where GI medical oncology has been lagging behind other tumor types. As in lung and breast, you are not going to ever treat a lung or breast with any chemotherapy unless and until you have that testing for HER2 or EGFR. But with breakwater data coming on, first-line HER2 trials coming on, I think it is slowly but steadily becoming a part of colorectal cancer practice.
Great. And we have 30 seconds for what might be the stupidest question ever, but antibody drug conjugates are all the rage, obviously, in breast cancer. Are any of those conjugates effective enough that we might test a combination in GI malignancy?
So trastuzumab deruxtecan, which is the HER2 and ADC, is already approved in colorectal cancer for HER2 IHC 3+ now. And we are doing currently some other studies with combination strategies to try to see if we can expand the scope of HER2 targeting in colorectal, like it is in breast, where it is also active in 1+ and 2+ cases.
All right. Good answer to a bad question. Thank you very much for your presentation. It's my
Thank you.
Extraordinary pleasure now to introduce Dr. Joe Unger from our Stats Center. Dr. Unger will be talking about a risk prediction model for acute care use. Joe, take it away if you're unmuted. I'm not seeing you either. If you're having trouble, you could put it in the chat. Oh. Can we help Dr. Unger unmute? Joe, any luck? While we figure this out, or maybe have Dr. Unger call in, is Dr. Patel here? Oh, we were going to do a recorded use anyway. So, Frank, why don't we show Dr. Patel's presentation? Oh, you're here?
It finally came through.
All right, we'll give you an extra minute. Go ahead, Joe.
Okay, sorry. Okay, thank you. Thanks, Chuck. Happy to be here today on behalf of my colleagues, especially Dr. Hirschman, who, despite all of her talents, can't be in two places at once. I'm presenting our paper, Development and Validation of a Risk Prediction Model for Acute Care Use Among Patients with Advanced Cancer on Clinical Trials. Next slide, please. So to start with some background, patients with advanced cancer are at high risk for unplanned emergency room visits and hospital stays during treatment, which can increase the cost of care. Acute care use can result in delays in the receipt of cancer care. So identifying patients at high risk could inform personalized intervention strategies to mitigate acute care use. Our objective therefore, was to develop and validate a risk model to predict acute care use in advanced cancer patients. Next slide. The data were from 6 SWOG trials for advanced cancer, 2 in prostate, 3 in lung, and 1 in pancreas. We used trial records that were linked to Medicare claims data by Social Security number, sex, and date of birth. We required that patients be 65 years or older to enable the linkage, and also that the patients have had continuous Medicare Parts A and B coverage for 12 continuous months before enrollment in order to detect baseline comorbid conditions, and for 12 continuous months after enrollment to identify utilization outcomes. Next slide. Our primary endpoint was healthcare utilization, which was defined as the occurrence of any hospital stay or emergency room visit within 1 year after enrollment. So it's really major utilization events. Hospital stay was defined using the MedPAR file in Medicare claims. ER visits were identified using 2 different data sources in claims, the outpatient revenue center data and also the MedPAR file. All ER visits and hospitalizations occurring within 1 year after registration were included, and there may have been potentially multiple observations per person. Next slide. We examined 23 different variables that could have potentially been predictive of utilization. Sociodemographic variables included age, sex, ethnicity, race, insurance, and year of trial registration. Geographic variables included rural versus urban location and area level deprivation measure. Clinical factors included underweight, prognostic risk, performance status, and disease type. And then we had 11 different categories of comorbid conditions that we defined at baseline using Medicare claims. These included autoimmune disease, coronary artery disease, diabetes, either overall or with chronic complications, hypercholesterolemia, hypertension, hyperthyroidism, kidney disease, liver disease, not livery disease, obesity, and peripheral vascular disease. Next slide. Model derivation was conducted in a 60% random sample, and it was tested in the remaining 40%. We used a regression method called method of best subsets, along with logistic regression to use that was combined with iterative application of 3-, 4-, and 5-fold cross-validation, each repeated 10 times. The variables selected in the best subsets model were used to calculate a risk score, and that risk score was calculated as the sum of the adverse risk variables that each patient had. And then this score was split at the median in order to test it in the validation set, and we also split it into quartiles. Next slide. The 6 studies that were included had 2,651 patients who were 65 or older, among which slightly more than half, or about 1,400, were successfully linked to Medicare claims data, and that was our primary denominator. In the 60% random sample training set, 34% of patients were 75 or older. Only 20% were female, although that was largely because of the inclusion of 2 prostate cancer trials. 8% were Black, and 60% had at least one comorbid condition. The overall proportion of patients with 1 or more hospitalizations or ER visits was 67.5%. And we found that participants in the training set were less likely to have aggressive disease, but were otherwise very similar in comparison to the test set. Next slide. The results showed that in the training set, there were 5 adverse risk factors that were identified. These included performance status, coronary artery disease, hypertension, and liver disease. There was also a study level variable that was identified, that was prostate cancer. Yes, first to know, that is to say whether they were on one of the prostate cancer trials. Because this latter variable was a study level variable, we tested whether there were differences in adverse risk between those with and without prostate cancer. This showed no interaction, which justified combining across all of the study types. So the final risk model included just the 4 risk factors: performance status, coronary artery disease, hypertension, and liver disease, and we adjusted for cancer type as a covariate. Incidentally, we also applied a machine learning model using gradient boosting, which largely confirmed the result, especially as it pertained to the top most predictive variables. Next slide. So in the training set, 2 or more risk factors was associated with a greater than 3-fold increased risk of utilization compared to 0 or 1 factors, with an odds ratio of 3.38. We tested this in the test set, and the results were largely consistent, validating the model. And as you can see there in the figure at the left, which shows the hospitalization and ER visit combined rate over quartiles, you can see that monotonic relationship. As the number of risk factors goes up in terms of quartile levels, the hospitalization ER visit rate, acute care use rate, goes up in a monotonic fashion. And in fact, in the highest quartile of 3 or 4 risk factors, that was associated with a greater than 4-fold increased risk of utilization compared to the lowest quartile, or 0 risk factors. Next slide. So in conclusion, the proportion with acute care use was high, about 68%. We found that comorbidity was a major contributor to risk of acute care use, despite the fact that these patients were selected for trial participation. A limited set of just 4 variables, many fewer than one would usually find in something like the Charlson comorbidity score, predicted risk of acute care use. Therefore, we conclude that identifying and targeting patients at the highest risk may be an effective strategy for interventions to mitigate this risk. Additionally, efforts are needed to ensure that adequate resources to prevent unplanned use of acute care in clinically vulnerable populations are needed. That's it.
Thanks,
Next
Jared.
slide. Sorry. There's one last slide, Chuck, and I just wanted to acknowledge all of our patients, especially, as well as our funding.
Appreciate it. So our operations manager wants to know how liver disease was defined.
Liver disease was defined using the claims data, and there's a number of different ways of identifying it. So there's an algorithm that we derived based on all kinds. It's kind of a catch-all. So it's just hard to summarize in one succinct category, but it was pretty easy to identify.
Great. And we have a question about the number of medications as a simple stratifier. Did you guys consider using that?
Number of medications on?
I assume the number the patients were on. You can look at the chat too, in case I'm reading the question incorrectly.
We did look at whether they were on their, we looked at whether they were on in their first line of therapy versus subsequent lines of therapy.
Great.
Yeah.
And I guess I'll take the prerogative of the last question. Your last bullet, number 4, making sure we have resources, very clear. Your third bullet, maybe we can mitigate or prevent some of this. A lot of your factors obviously weren't all that adjustable. So do you have thoughts on how we would actually prevent some of these hospitalizations or ER visits?
I think it's more, it's about identifying the patients at risk so that you can, employ strategies that are maybe helpful in identifying patients on kind of going downhill before it actually happens. There are a lot of things that have been established recently that are about improved monitoring of patients, including patients self-reporting of their own conditions through patient-reported outcomes, vis-a-vis Ethan Bosch's work. That is one option I think that is important for trying to interrupt a patient's downward trajectory by early identification.
Perfect. With that, we will close out. Thank you so much, Dr. Unger. It turns out our DART team is apparently just as busy as Dr. Hirschman, and we couldn't identify any that didn't have an obligation, but that trial is just too important to ignore. So we have a pre-recorded presentation on DART, including some recently unembargoed, not necessarily data, but at least the title of including vaginal cancers. So Frank, please play the tape. I'm not hearing it. I don't know about others. Looks we are light on audio. Frank, are we sure the audio itself was a recording when this was made? Is it a projection issue or a recording issue, or do we know?
It was recorded, and it
Okay.
was playing when we ran through. No.
Thank you. Maybe, well, I guess we won't really know unless we keep playing with it, but I do believe Dr. Thompson is on. I don't know, Frank, you're our tech person. You want to keep trying for one more second?
S1609 DART team and my co-PIs.
Asked and answered.
I am Sandip Patel, and I'm honored to be presenting on behalf of the S1609 DART team and my co-PIs a phase 2 study of dual anti-CTLA-4, anti-PD-1 blockade in rare tumors, or DART, SWOG S1609. Rare cancers, while individually are quite rare, overall represent almost a quarter of cancer burden worldwide, and in particular affect younger patients. DART sought to be the first basket immune checkpoint blockade study investigating multiple rare tumor types, initially in 2017 with 33 cohorts, and from 2021 to study closure, 53 different rare tumor histologies. The schema involved objective response rate as the primary measure for the Simon two-stage design, in which patients had imaging assessments by CT and RECIST every 2 months initially. The regimen, to note, was ipilimumab 1 milligram per kilogram every 6 weeks with nivolumab every 2 weeks continuously. So the thoracic oncology dosing, as opposed to the melanoma or renal cell carcinoma dosing of dual immune checkpoint blockade. At the time of S1609 study closure in March of 2023, 798 accruals with 53 cohorts. Some cohorts of interest. The neuroendocrine cohort was the first cohort to read out positive. Immune checkpoint blockade with monotherapy had a 5% objective response rate. Here there are 32 eligible patients, about half were high grade, and almost half had GI tumor as their primary site. We did not see a correlation between response and primary organ site. However, when we categorized by grade, we noticed that patients with high-grade neuroendocrine neoplasms either had the most elite responses or unfortunately had continued progression of their disease. Those patients that did get a response to dual immune checkpoint blockade had durability of their response lasting over a year and years in many cases, independent of the primary site. And so we noticed that the objective response rate was 44% for high-grade neuroendocrine carcinoma, although this is not a pre-specified analysis at this time, and the clinical benefit rate trended similarly. The toxicity, predominantly related to liver dysfunction and endocrinopathy. High-grade colitis was presented in 6% of patients. So to determine whether high-grade neuroendocrine patients were the group that benefited the most, a prospective cohort only involving high-grade neuroendocrine patients was enrolled to within DART. This is a separate set of patients. These are 19 patients, all confirmed to be microsatellite stable. The objective response rate was 26%, with similar durability in those patients that did respond, grade 3 rash being the most common immune-related adverse event. As shown here, with nausea and GI symptoms being the second most common side effect. Here, as mentioned, about 1 in 4 patients had a partial response, 5% of patients with durable, stable disease, and independent of primary site, as shown here. And with some patients with responses lasting years, despite heavy prior pretreatment. And so across neuroendocrine tumors, DART showed efficacy, especially in high-grade patients. The future-facing cohort with de novo patients had 21 accruals in 8 weeks, really showing the ability for DART to accrue even in rare tumors with a platform-based strategy, suggesting a durability response. However, there are other cohorts that are of interest as well. Angiosarcoma was investigated in DART, and you see here that cutaneous angiosarcoma, in particular of the face and scalp, had some patients with shrinkage of tumor with durability of benefit. Meanwhile, those breast sarcomas, which are typically more common radiation-induced sarcomas, did not have similar response rates in our study. Here again, ipilimumab plus nivolumab. Metaplastic breast cancer, which very much like a teratoma has multiple embryonal histologies within the tumor, poor response to cytotoxics, typically microsatellite stable with low TMB. Here is a patient with near complete remission. You can see both cutaneous as well as by imaging. And so in DART, there are 17 patients accrued with metaplastic breast cancer, 1 CR, 2 partial responses, and yet again, durability here for advanced disease with responses lasting years, though the subhistology here did not confer or inform which patients responded to treatment. Clear cell ovarian cancer, another tumor for which patients with refractory disease often do not have durable responses. Here yet again, some patients up to 3 years and beyond with durable responses to ipi-nivo, though there are many patients, unfortunately, who do not respond. Another ovarian subtype, small cell carcinoma of the ovary, predominantly affecting younger patients, hypercalcemic subtype. Here we had 2 patients with response, 1 with a durable response on treatment. Ovarian granulosa cell tumor, another rare ovarian cancer subtype. Here we see 3 patients with durability of response, 2 with radiographic responses in our study. Our statistician, Dr. Ovis, led an analysis across multiple arms of the study, looking at the development of an immune-related adverse event in the first cycle of treatment and survival across multiple study arms, all 53 cohorts. And interestingly, those that patients that had low-grade immune-related adverse events had better outcomes than those patients who did not have any immune-related adverse events or had high-grade immune-related adverse events, best explained by toxicity causing negative survival outcomes, and that low-grade toxicity potentially indicating that an immune effect had developed in that patient, which may have anti-tumor effect as well. Also, that change in tumor size by RECIST, another analysis led by Dr. Othis, across multiple cohorts, correlated progression-free survival and overall survival. Many of these rare tumor types are very hard to measure by RECIST, but here, despite that headwind, those patients that did have RECIST responses tended to have a durable survival on our study. This is a more discrete view showing that the change in tumor size, the increased depth of response, let's say minus 60% or greater tumor shrinkage, the better your survival, as demonstrated here on the y-axis. Now, one of the key questions, we've shown you multiple different tumor types for which we had responses within that tumor. Some patients responded, some did not. And so it turns out histology doesn't inform which patients will respond, nor does PD-L1 and TMB in our analysis. So we partnered very closely with the CMAX and NCI and MD Anderson for our CMAX in particular to look at other biomarkers that may inform which patients within a given histology may respond to treatment, looking both blood-based as tumor-based markers. And so to summarize, that we have an efficacy signal with ipilimumab and nivolumab across multiple tumor types, including high-grade neuroendocrine carcinoma, angiosarcoma, metaplastic breast cancer, and select rare ovarian cancer cohorts. I think more importantly, clinical trials in rare tumors are feasible. The study was open at over 800 sites. 2/3 of these patients were treated in the community setting. Across 3 years, we enrolled almost 800 patients across 53 cohorts, and we were able to do confirmatory signal discovery as well as validation for rare tumor cohorts in the study, as demonstrated by the high-grade neuroendocrine carcinoma study. And equally important, understanding the immunobiology so we can define which patient populations may benefit from particular treatment strategies. These analyses are very important. They're underway as part of the CMAX. So with that, I want to thank the S1609 DART team for making this study happen, and happy to have any discussions related to the study.